The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, all you TMD warriors. I am Tony Urbanek, and we're here for the next episode of TMD Demystified. Welcome, and congratulations for being here. Today, I selected the topic, very simple topic. We're going to continue on with a series that we started several weeks ago, the scandal, TMD, the scandal. So today it's TMD, the scandal, part 4. And part 4 is misdiagnosis earaches. So as I said before, and I don't want to be too dramatic, but I think maybe this deserves a little drama because it's so common and really common and costs patients and doctors a lot of time and a lot of heartache, including earache, a lot of money that is misspent, misdirected, a lot of misdiagnosis, and a huge amount. I cannot give you the measurement, but I know that it turns into not hundreds of patients, not thousands of patients, certainly hundreds of thousands of patients extrapolated from my experience here in just Middle Tennessee, and possibly millions of patients a year. I don't know for sure, but hundreds of thousands, that's not hyperbole. That is not excessive estimation. Because on a routine basis, on a almost daily basis, I mean, if we see 5 TMD patients consultations per day, at least 3 of them have a history of going to the PCP or the walk-in clinic with a history of earaches, which have been initially misdiagnosed as ear infections. Misdiagnosed earaches, ear infections. I don't really know why, because, well, I do know why. I can explain it. That's what we're going to do today. I'm going to explain it why that is. I'm going to explain how that comes to pass. I'm going to explain why it shouldn't be. And I'm going to explain how you can end up with a symptom that feels just like an earache, but it's coming from the temporomandibular joint. I will show you that. Definitely. And in this case, dramatically in diagrammatic form, coming directly from the anatomy text. So here's the situation. On a routine basis, we have coming into our practice here in Middle Tennessee from one or more of the 700 plus referral sources that we have sending us TMD patients. Patients that come in and say, I had an earache and I went to the walk-in clinic. This is the most common. Nowadays, 70% of people go to walk-in clinics rather than their doctor, PCP. And 70% of those patients who go to walk-in clinics, their primary complaint has something to do around or about the head and neck. Pain around the head and neck, dizziness, vision problems, what they think are sinus problems, but something having to do with the head and neck is 70% of the people that go to walk-in clinics. So figure it out for yourself. Earaches are very common. There are certainly such things as ear infections, which cause earaches. An ear infection will undoubtedly cause an earache. The infection gets into the middle ear and causes inflammation in the middle ear, and it causes protuberance or expansion of the tympanic membrane, which you can easily see with an otoscope through an otoscope into the external auditory canal. I should have gotten my otoscope out. showed you what an otoscope looks like, but oh, maybe I will. In any case, using an otoscope, typical piece of equipment that any dentist or any physician has in his office or walk-in clinic, immediate care clinic, can look up the external aortic canal, which goes up and forward. Reason sometimes you can't see it is it doesn't go like this. You have to kind of look up and point it forward and up, and you can see the tympanic membrane. And, you know, with a good light on the otoscope, you can easily see where that tympanic membrane is swollen or whether it's red. And if it's swollen and red, you have an ear infection, at which point it should be treated with antibiotics, at which point within 2 or 3 days, the infection will diminish and the pain should go down. That's typical ear infection. I do not know what the proportion is between ear aches that vary between ear infections and temporomandibular joint being the cause, inflammation of the temporomandibular joint being the cause. That would be a good study. But we're already well into multiple studies that we need to do that we don't have time to do yet. And there's many studies ahead of that one. But that is a good study to make in relationship to figuring out, you know, how much of these symptoms come from the temporomandibular joint and what percent come from other causes. But today the topic is ear infections and ear aches versus ear pain coming from the temporomandibular joint. So the scenario is, as I started saying, is the patient goes to the walk-in clinic with an earache. And the nurse practitioner or physician's assistant at the walk-in clinic gets out the otoscope and takes a look into the external auditory canal at the tympanic membrane. And what surprises me, and I think it's because the physician's assistants aren't experienced as much as, say, an otolaryngologist, ENT is, or an oral and maxillofacial surgeon is, about looking into an ear canal. Now, by the way, as long as I keep talking, let me get my otoscope. I apologize for that. I should have prepared a little bit better, but so this is an otoscope. I'm sure, I would imagine you all seen these before, had one used on you. It has a light behind it. The battery's dead on this one, so I can't do that. It has a cannula that goes over it. And basically, you look at it by like that. Forward and up will take you right up the external auditory canal, and you look right in the view, which is a little magnifier, and you should be able to see a just beautiful view of the tympanic membrane. Works really well. And so I am surprised at the number, and have been surprised at the number of primarily nurse practitioners who misdiagnose an ear infection for a temporomandibular joint inflammation. We're going to talk about why that is, but it happens. And the patient, and many patients, they'll go back to the walk-in clinic, the immediate care clinic, several times. You know, they'll get the typical experiences. The nurse practitioner says, you got an ear infection, here's some antibiotic and penicillin, amoxicillin. Take this for 5 days and the pain should go away. So they get the prescription, take it for 5 days, they still have the pain. They go back to the walk-in clinic, she takes another look at it and says, well, you just need more antibiotic. That has happened many times, I've been told, by our own patients. Second prescription for antibiotic doesn't help. Finally, they go back the third time to the immediate care clinic, and the nurse practitioner, whether they look in the ear again or not, they say, I'm going to send you to an ENT, otolaryngologist. And the otolaryngologist, once the patient gets into their office, takes a look in the ear with the otoscope and say, you don't have an ear infection. And at least around here in Middle Tennessee, most of our ENT doctors, not all, but most, we've addressed most of the ENT docs here in Middle Tennessee. Most of them at that point will say, you don't have an ear infection. And they'll do this little examination. And the patient reports, the doctor put his fingers and did a little of this on my jaw joints, which is inaccurate way to do it. It's like this, open widely, a lot of pressure with your fingertips in the glenoid fossa, bite together quickly. If it elicits pain, you have inflammation within the temporomandibular joint, and the problem is TMD, not ear infection. And the ENT doctor will do that little maneuver because we've taught them to do that. And they will say, you have TMD and you need to go see Dr. Urbanik and staff. And so we get lots and lots of referrals from ENT doctors, but that basic scenario precedes going to the ENT doctor unless the patient themselves self-referred into the ENT, or the PCP who was confused about what's going on referred to the ENT. And then, of course, we get lots of referrals from PCPs now who are becoming more enlightened about distinguishing between ear infections and temporomandibular joint pain that can be confused with ear infections. So that's why we're having this particular discussion, and that's why I chose this topic, because it's really common. It's really common. It is common along with the others that I addressed, the other portions of what we call Meniere's disease, which is ringing in the ears, tinnitus, subjective hearing loss, fullness in the ears, and vertigo, dizziness. Those three are the three components of Meniere's disease that are almost always confused with temporomandibular joint inflammation and pain causing those symptoms. And we discussed in previous episodes how there may not even be a Meniere's syndrome. I wouldn't swear to it. I'm not trying to say there is. A really easy and good study can discern whether patients who come in with one or more of those symptoms actually have Meniere's disease, which the ENT doctors absolutely say and admit they have no treatment for and don't know really what causes it. But we do know what causes ringing, fullness, and dizziness associated with inflammation within a temporomandibular joint. Back to infections, back to ear pain, earaches. So that is the very, very common scenario. Daily almost, we see that. And if I see it daily, then if you pay attention in your practice, you're going to see it daily if you see enough patients. And my job is to stimulate our network providers, current network providers, and encourage new network providers throughout the US and beyond to use this technology and knowledge that I have that I'm sharing with you right now to actually solve this problem so that all this time and money is not wasted and patients do not have to go through years, and I don't exaggerate that, years of these symptoms that are misdiagnosed, mistreated, misdirected. Enough said. So how does inflammation within the temporomandibular joint get confused with ear infections? So I, being the anatomist and cell biologist that I am, that I was trained as, I just looked around, didn't take me but a few minutes, and pulled up that anatomy diagram, which is, I'm going to explain this in detail to you because once you see it, you can see it, but until you see it, it just kind of looks super confusing, like everything else that you did when you studied gross anatomy or histology or whatever while you were studying the basic sciences in dental school. So let me go through this carefully. This is first, and I'll do it slowly because when I first came across this, I said, this is perfect, but I had to get it in mind of what we're looking at. So this is a coronal view, meaning it is a section through the crown down, a coronal view from the crown down, looking at this would be the right temporomandibular joint, and ear canal. So this is the helix of the ear, this thing, and this is the external auditory canal. This is the tympanic membrane that separates the middle ear from the external auditory canal. This is the thing, the item, the anatomic structure that you would be looking for to be swollen and red if you have an ear infection. And the infection can be superficial, or the infection could actually be behind the tympanic membrane back inside the middle ear. But it would come across, and actually infection would look with the tympanic membrane is red and swollen, poking out. All right, so coronal view on the right side. So this is where my pointer is. This is anterior. This is posterior. This is the cerebral cavity, brain cavity here. This is external right. This is medial, anterior, and posterior. All right, so once you kind of get that down, let's take a look and focus on this area that I'm outlining right here. You have a coronal section through the condylar head. This is the condyle, kind of the most superior part of the condyle. You can see the internal portion of the condyle, the cortical portion of the condyle, and then the external auditory canal. Now, I want you to envision if you had this entire structure around the condyle inflamed, especially the superior portion of this where you have the meniscus and the ligaments associated with the meniscus and the condyle. And when they are inflamed long enough, you get inflammation causing your typical headaches, jaw pain, shoulder pain, neck pain, etc. But in this case, looking at this diagram, it is easy to see how inflammation within the space of the glenoid fossa, temporomandibular joint, can penetrate these little festrations, which are, for the most part, bony versus slash cartilage items, structures. Now, here you can see that it's indicated, drawn out as bone, but as you come out laterally, this is the tragus, that is the little cartilage portion right before the external auditory canal, which you can move around. It's a piece of cartilage inside. In fact, as a maxillofacial surgeon, if you wanted some cartilage to put in the nose, or we wanted a nice piece of cartilage someplace, this would be a good place to get it from. We get a nice piece of little cartilage right from the tragus of the ear. Nobody misses it. But the point is, then, this is cartilage. These two little pieces indicate cartilage, and then it varies as it gets more medial into bone. But you can see in this area that there are small fenestrations, windows, that would allow inflammation cells and cellular fluids and exudates to penetrate through these fenestrations onto the mucosa. This is not necessarily skin in here, and it's not necessarily mucosa. It is the covering of the external auditory canal, and you can see how inflammation can get through those fenestrations and on the medial or inside portion of that tissue, which can cause then this tissue to be inflamed, and of course inflammation causes pain. And the painful registrants are nociceptors that are located on the surface of the periosteum or the perichondrium. So let's unpack that just a little bit. Just to say, these little anatomical structures indicate small pieces of cartilage like the tragus. It's covered by a perichondrium, which is extremely similar to a periosteum, which would be the covering of this area right here. That would be, because it's bone, that would be considered periosteum, and covering these small structures, including the tragus, would be considered perichondrium, and the nociceptors, noci meaning pain, septors, meaning receptors, are located on and within the perichondrium and the periosteum. So when inflammation gets into this area and beneath this tissue, mucosa, and depending on how far it's out, it could be considered skin. The inflammation will cause pain because it stimulates the nociceptors, and it comes across to the patient as an earache. There's your earache right there, not here. So the nurse practitioners look in here, and when they stick the speculum through this area right here, and the patient will go, ouch, ouch, it hurts. Of course it hurts, because this area and beneath it is inflamed and it's being stimulated. The nociceptors are being stimulated. And when you push on this or even put your finger on it and push forward, it hurts. And patients will come in and say, yeah, it hurts, right? And they'll put their finger in their ear and they'll push forward right in this area. And they go, I've had an earache and I went to 2 walk-in clinics, or I went to one walk-in clinic twice and another walk-in clinic once. And finally, that walk-in clinic nurse practitioner said, I need to go see an ENT. The ENT took a look at me after I had the pain for an additional week and a half before I could get an appointment. And he looked at my ear and said, you don't have an ear infection, you have jaw joint problems, you have TMD. Go see Dr. Urbanek. That is such a common story. And that is exactly why that is right here. So this is the glenoid fossa, the interior of the temporomandibular joint. When it becomes inflamed long enough, the inflammation can penetrate through those fenestrations and around the perichondrium, causing inflammation and stimulation of the painful sensors, giving the patient an earache. And as they move the jaw back and forth, whether it's their finger in their external auditory canal pushing on it, or their mandible going back and forth, translating, rotating and translating. Here's the rotation and here's the translation within the temporomandibular joint. As it does that, it puts pressure back here, and they say, when I try to eat, it hurts and I have an earache. Or, I know I'm grinding my teeth, but I get an earache in the middle of the night. And things like that. And then they start the process and start out at the convenient care clinic. So a little knowledge of anatomy and cell biology having to do with inflammation, which is a relatively complicated topic, inflammation. We don't know it all that we need to know. We don't have all the answers about inflammation. We have a lot of information, and as I've said many times, I personally believe that the ultimate solution for all, if not most, of our cancers is going to come from a full and complete understanding of inflammation. I believe if we absolutely, totally understand inflammation, we're going to have the answer to a lot of different diseases, including cancer. We'll see whether I'm right or wrong. Maybe I won't live to see it. But the point is, that is what I believe, informed knowledge and experienced knowledge. So, as a practitioner of treating people with TMD, it's really simple. And I do these episodes to emphasize the simplicity of all this if you just understand it a little bit. We are taught in dental school. I have never had one of my dental colleagues tell me anything but this. They are taught in whatever dental school they went to that the temporomandibular joint is an extremely complex joint. In fact, I just saw it today on a video I was watching on YouTube, which is not a true statement. It is a false statement. The temporomandibular joint is not a really complicated joint. It operates no different than any other joint in the body, except it has a couple different unusual motions. But the pathology and the physiology of how that joint works, how the temporomandibular joint works, is no different than the knee or the elbow when you really get down to it. And then it has a little different shape, and it's definitely smaller, and it is much more exposed to damage than, say, the knee or the elbow. Because what are you doing? You're chewing all the time, you're talking all the time. And if you're one of the 50% of the population that has a habit of bruxing, you are at high risk to cause significant long-term inflammation within the joint, which in turn causes all the symptoms of TMD, frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling, and numbness, and various kinds of locking. So, for our topic today, the TMD scandal part 4, misdiagnosis, earaches and ear infection versus TMD. I think I spelled it all out. I hope I've done it carefully. I'm appreciative of whoever the author was that drew this anatomical diagram, because it is exactly what I needed to explain this to all of you viewers. So for today, I'll wrap it up. I always encourage and appreciate any comments out there about my presentation or criticisms about what I try to teach, or whatever you want to criticize. I'm up for it. I will respond to it if you care to communicate in any way, shape, or form. I encourage any doctor viewers who want to participate in the correction and the successful solution for non-surgical TMD symptoms to join our network of doctors, growing network of doctors throughout the United States and beyond, who now use our simple non-surgical intraoral temporomandibular joint device and protocol to relieve the inflammation within the joint, which relieves all the symptoms. That's called the Urbanic device. You can reach me at tony@tmjservices.net. You can reach our Director of Marketing and Education, Naomi, at tmjservices.net. Our website is www.tmjservices.net that encourages you to gather more information, gives you a plethora of information regarding our company, how we serve patients, how we can encourage you to be a member of our network so you can develop your own practice, a very successful practice in treating TMD non-surgically, and add it to your menu of services that you can provide in office, or even have a practice specifically and devoted exclusively to non-surgical treatment of temporomandibular joint. We now have one doctor in our network, and that is exactly what he is doing. He has devoted his entire practice to treat TMD non-surgically. He is a member of a larger dental network, and he has other doctors in his network of providers, dental services organization, who have then earmarked him to send all their TMD patients. So there's many ways you can get involved for the benefit of your practice and yourself and your income, and especially the patients who are just in great need of getting this problem solved permanently. We have to stop the misdiagnosis of this. The problem is so severe. The outcomes are so disabling to so many people, and it is just not recognized by our medical colleagues and by many of our dental colleagues. It just is not recognized for what it is. So we'll leave it at that. I appreciate your time and attention. Until next time, I am Tony Urbanic, and this is TMD Demystified.